Hello, doctors. So, today we'll be discussing a very important topic, and that is approach to anemia. So, before getting into the topic proper and discussing the different parallels of the topic, we'll understand the applied physiology first. So, we'll be dealing with the applied physiology first. So, first of all, you need to understand the concept of erythropoiesis. What is erythropoiesis? Erythropoiesis is nothing but the process of production of red blood cells. So what are the sites? So sites in fetus. So this can be remembered by a very important mnemonic, that is young liver synthesizes blood. And the first letter of each word stands for the sites. Like for example, Y stands for yolk sac, and erythropoiesis over here takes place from 3 to 8 weeks of intrauterine life. Okay. Similarly, L or liver over here, erythropoiesis occurs from 6 weeks to birth. Then S stands for spleen. Over here, erythropoiesis occurs from 10 to 28 weeks of intrauterine life. And in B stands for bone marrow. Over here, it occurs from 18 weeks till birth. So young liver synthesizes blood, yolk sac, liver, spleen, and bone marrow. Whereas we all know that in adults, erythropoiesis occurs in bone marrow. Okay. Now, after understanding these sites, we'll get into the entire process of how the RBC is formed. So, there is a cell known as pluripotent hematopoietic stem cell. PHSC. Now, this cell can form progenitors. Like it can form myeloid progenitor, or it can form lymphoid progenitor. So pluripotent hematopoietic stem cell. Pluripotent means it can form more than one type of cell. This is the meaning of pluripotency. And stem cell means it is a germline cell. Okay. So there can be from PHSC, pluripotent hematopoietic stem cell, myeloid progenitor can be formed or lymphoid progenitor can be formed. Now in myeloid progenitor, further it can divide into A, erythroblast, B, megakaryoblast, and C, myeloblast. Okay. Now erythroblast will form RBCs. As the name suggests, erythro means erythrocyte RBC. Megakaryoblast will form platelets. Myeloblast will form neutrophil, eosinophil, basophil, and monocyte. Monocyte further divides into macrophages when it goes into tissue. Okay, so monocyte, when it goes into tissue, it divides into, or it transforms into macrophage. Okay, now this lymphoid progenitor will transform into lymphocyte, T lymphocyte, B lymphocyte, and natural killer cell. All these have distinct functions which we'll discuss further when we'll discuss immunity. Okay. B lymphocyte per se will divide into or transform into plasma cell, which will form antibody. So if you are asked which cell secretes antibody, the exact answer is plasma cell, which is a type of B lymphocyte. Okay. Now we'll be dealing with this. How this is formed per se. Okay. So as soon as pluripotent hematopoietic stem cell starts dividing for erythropoiesis, so pluripotent hematopoietic stem cell, it divides first. This is the cell. It divides into BFU erythrocyte. So pluripotent hematopoietic stem cell divides into BFU erythrocyte. Okay. Now BFU over here stands for burst forming unit. Burst forming unit. Okay. Now BFU will further divide into colony forming unit, CFU erythrocyte. colony forming unit erythrocyte. Now colony forming unit erythrocyte will then divide into or mature into proerythrocyte. Okay, so this is your proerythrocyte. This is important. Now proerythrocyte will then divide into basophil erythroblast. Okay, this is known as basophil because it stains with basic dyes. It stains with basic dyes, remember this. Fine. So this is your basophil erythroblast. Then basophil erythroblast divides into further into polychromato polychromatophil erythroblast. This is polychromatophil erythroblast. This will divide into orthochromatic erythroblast. So this is your orthochromatic erythroblast, and this will divide into a very, very, very important cell, and that is known as reticulocyte. And reticulocyte will divide into mature RBCs known as erythrocyte. What are the things which you need to remember over here? I'm going a bit slow so that you can understand. So you need to remember few salient points. First is pluripotent hematopoietic stem cell changing into burst forming unit erythrocyte. This step is EPO dependent step. EPO means erythropoietin dependent step. This you need to know. Okay. Then this transformation from BFU to CFU is the first EPO dependent step, and it takes nearly 10 to 14 days. So this particular step takes 10 to 14 days. Okay. Now third thing, again very important, regarding reticulocyte. So reticulocytes, you should know first, mature reticulocyte lacks nucleus. Mature reticulocyte lacks nucleus. We have heard of the very fact that RBC lacks nucleus. Okay. So this nucleus, exclusion of nucleus from the cell occurs from reticulocyte step, and mature reticulocyte itself does not have nucleus. Second thing about reticulocyte is very important, and that is reticulocyte enters the circulation and matures into erythrocyte. So this cell, the RBC, enters circulation at what step of erythropoiesis? We'll answer reticulocyte. So reticulocyte enters the circulation and matures into erythrocyte. Fine. These are the things which you should know. So we have seen the sites, we have seen the steps. Okay. Now, third thing is the definition of anemia. The definition of anemia. Okay. So anemia is defined as decrease in RBC count, very important, decrease in RBC count or hemoglobin content for this line is very important, for given age and sex. So you should know these things. First, decrease in RBC count. Second, decrease in hemoglobin content. Okay, for a given age and sex. Okay. Now we should define what is normal. Then only we can define that below what level is anemia for given age and sex. So normal value of hemoglobin in males and in females. Okay. So in males the cutoff is 15.5 plus minus 2.5 gram percent. And in females it is 14 plus minus 2 gram percent thanks to menstruation, thanks to menstrual loss. Okay. Now, what is the hemoglobin cutoff for anemia? Now, we'll again define as per sex. So, in adult male, hemoglobin less than 13 gram per dl is defined as anemia. An adult female, hemoglobin less than 12 gram per dl is defined as anemia. And in pregnancy, you should know, and in pregnancy, hemoglobin less than 11 gram per dl is defined as anemia. So we have seen the normal values of hemoglobin. In male it is 15.5 plus minus 2.5 gram percent. In female it is 14 plus minus 2 gram percent. And the cutoff, normal cutoff, other than normal, the cutoff in adult male is less than 13 gram percent. In adult female it is less than 12 gram percent. And in pregnancy it is less than 11 gram percent. Now, why is this value so less in pregnancy? The cutoff in pregnancy is so less because in pregnancy we have something known as dilutional or physiological anemia due to hemodilution. Dilution, since there is expansion of plasma volume. The mechanisms which you will study in obstetrics. Okay, so there is hemodilution leading to a decrease in cutoff. Okay. Now, after discussing all these things, I think now it's the time that we should look into the core concept of reticulocyte. reticulocyte count and all. Okay. So why is reticulocyte so important? See, since RBCs enters the circulation at this step, that is at this step of reticulocyte. Okay. So this particular cell is very important when we are dealing with anemia. Why? We'll look. See, the normal reticulocyte count is 0.5 to 1.5%. That is between 25,000 to 75,000 per microliter. Okay. Second thing which you should know is stains for reticulocyte. What are the stains used in lab for reticulocyte? So we have two stains. First is brilliant crescile blue. Second stain is new methylene blue. New methylene blue. These are the two stains used in labs for reticulocyte. Okay. Now on the basis of reticulocyte count, we can classify anemia into hyperproliferative and hyperproliferative anemia. Okay. So on the basis of reticulocyte count, retic count can be low or at a higher side. Okay. So if it is at a lower side, it is known as hypoproliferative anemia. Very, very important concept. Hypoproliferative anemia. Okay. And if retic count is at a higher side, it is known as hyperproliferative anemia. Okay. Fine. Now this classification can quantitatively decided on the basis of reticulocyte production index also. How? See, there is something known as reticulocyte production index. In short, we call it RPI. The formula for RPI is hemoglobin of the patient divided by the desired hemoglobin that we have discussed over here. This is the desired hemoglobin. This thing is the desired hemoglobin. Okay. So hemoglobin content of the patient divided by desired hemoglobin into the reticulocyte count, retic count divided by 2. Fine. This is the formula. Now on the basis of this, if the RPI is less than 2, it is known as hypoproliferative anemia. Fine. And if RPI is more than 2, it is known as hyperproliferative anemia. Fine. Retic count less than 2, hyperproliferative. Retic count more than 2, hyperproliferative. Retic count at a lesser level, it is known as hyperproliferative. Reticount at a higher level, it is known as hyperproliferative. Both ways we have seen. Now, the most important topic of this discussion, we are landing into that. What is the approach to hypoproliferative anemia? Fine. This is the most important topic. So, in approach, whenever a patient comes to you, he'll complain of what? He'll complain of typical complaints. There'll be a female patient with complaint of either tiredness, headache, or swelling in feet, shortness of breath, dyspnea, or she'll have menstrual anomalies, menorrhagia and all that. And on examination, she'll appear pale. I hope you people know where to check for pallor. You have to check for the upper palpebral conjunctiva, and we can check on the tongue, on the palm and all. There can be edema, all that. We'll discuss it later, but on examination we'll find. So this is a clinical, upon clinical suspicion, we'll go for lab diagnosis. So in lab diagnosis, you will look for whether you are dealing with a single lineage problem or a tri-lineage problem. First of all, you have to look for this. Lineage means the cells. Which cell? We have already discussed. This is the lineage. Single lineage means only the erythroblast and this cell is involved. Tri-lineage means the entire RBC and the lymphoid cells, everything that is also involved. So if you are dealing with single lineage problem, you will only have decrease in RBC or hemoglobin with normal total count and differential count. If you are dealing with tri-lineage problem, you will have decrease in total count as well as differential count. This tri-lineage problem is an entire different game altogether, and we'll discuss it in some other topic. So per se, we will discuss the single lineage problem over here. So we have seen, yes, the report is pointing towards single lineage problem. Now we'll look for the reticulocyte production index. So if it is less than 2, we'll call it hyperproliferative anemia, hypoproliferative anemia. If it is more than 2, it is a case of hyperproliferative anemia. Fine. What does hypoproliferative mean? Hypo means decrease in production of RBC. Hypo means less. So there's decrease in production of RBC. Hyperproliferative, hyper means high, proliferation means production. So there's increase in production of RBC. Why there's increase in production? Because there is RBC lysis, known as hemolysis. Okay, there's lysis of RBC, and this will cause a positive feedback via your erythropoietin. This will activate the bone marrow, okay, so that there is increase in production of RBC. Okay, so this is the reason for hyperproliferative anemia in hemolysis, in a case of hemolysis or hemolytic anemia. So hyperproliferative means hemolytic anemia. Clear? Now, if it is a case of hypoproliferative anemia, then we'll look for mean corpuscular volume, MCV. So the normal value for MCV is, the range is between 80 to 100. So if it is between 80 to 100, it is normal. Then it can be less than 80, which means it is a case of microcytic anemia. If it's more than 100, MCV is more than 100, it is a case of macrocytic anemia. Okay. Now, what are the causes of microcytic anemia? It can be remembered with a mnemonic SITA, SITA. S stands for sideroblastic anemia. This has been asked in many exams, MCQs and all. So remember, S stands for sideroblastic anemia, I stands for iron deficiency anemia, T stands for thalassemia, very important, these two anemias, and A stands for aplastic anemia. Aplastic anemia. We'll discuss each when we'll discuss the anemia topic per se. Okay, fine. Microcytic में you'll have SITA. Then in macrocytic anemia, if on peripheral blood smear you find megaloblast, then look for whether B9 level is low or whether vitamin B12 level is low. Okay, here you will also check for methylmalonic acid and all. We'll discuss it later, but for simplification purpose I am telling, if you find megaloblast on peripheral blood smear, then look for whether B9, vitamin B9 level is low or vitamin B12 level is low. If B9 level is low, you will designate it as a case of folate deficiency anemia. And if B12 is at a lower side, you will designate it as a case of pernicious anemia. Pernicious anemia. Very important. Okay. Now, if on peripheral blood smear you find they are normoblast, then it is a different thing. Okay. This was when you are dealing with hypoproliferative anemia. In hyperproliferative anemia, remember that it can be either intravascular hemolysis or it can be due to extravascular hemolysis. Extravascular hemolysis. In extravascular hemolysis, you can have immune versus non-immune hemolytic anemia. Hemolytic anemia, and this is decided by Holmes test. Fine. So we have discussed whenever you have clinical suspicion of anemia, and that is very common case in clinical scenario, we'll go for the peripheral blood smear and the cell count. Suppose you are dealing with a single lineage problem, which will be evident by decrease in RBC count and hemoglobin content with normal T total count and differential count. Then first thing we'll look for reticulocyte production index. If it is less than 2 or more than 2, accordingly we'll decide whether it is hyperproliferative or hyperproliferative anemia. Then we'll look for MCV. If it is less than 80, then it is a case of microcytic anemia. If it is a case of microcytic anemia, then there are 4 causes, but 2 very important causes: thalassemia and iron deficiency anemia. Now the question is how you will differentiate between iron deficiency anemia versus thalassemia. How you will differentiate between these two. Right? So there's a concept of Means-Zer index. Means-Zer index. And the formula for this is very important index, Means-Zer index. The formula is mean corpuscular volume divided by RBC count. Okay. So if this index is more than 13, it is a case of iron deficiency anemia. And if it is less than 13, it is a case of thalassemia. This has been asked in many MCQs exam as well as in Viva work also. So Means-Zer index, MCV by RBC count. So if you are asked how we will differentiate between a case of iron deficiency anemia and thalassemia, which is very common in clinical practice also, so we'll decide it by Means-Zer index. Okay, how will remember this? See, very important, very easy trick to remember is over here is this I in iron deficiency anemia means increased. Increase in what? Increase in Means-Zer index, that is more than 13. So if Means-Zer index is increased, that is I, that is iron deficiency anemia. Okay. So we have seen all important aspects of the approach to anemia as well as the applied physiology part. So in the next part, we'll discuss the detailed approaches of iron deficiency anemia, thalassemia, and different hemolytic anemias. Okay, so keep studying, keep learning. Bye bye.